Oh, I'm talking about the discoid meniscus. This is another thing that we find adolescent. Yeah, it's congenital. But sometimes patients come to see us when they get older, not that young. And a lot of patients that come to see me, sometimes 40, sometimes 60. The oldest one is 70 years old. Okay, discoid meniscus. So I have to thank this Professor An from Korea. He's my great teacher. I learned the discoid meniscus from him because I think he's a world authority. Okay, because this discoid meniscus is very common in Korea, in Japan, right? I'm not sure in Hong Kong or not.
Not as common.
That's common. Yeah, these two countries, Japan, Korea. In Thailand, not that common. So discoid meniscus, yeah, this is the first described in 1889, okay, by Young. Most common in lateral side, okay, so we never see that on the medial side. 20% cases are bilateral, and high prevalence in Asian countries like Japan, Korea, okay. Only 5% in US. You see, a lot difference. This is the. So first of all, we need to look at this. This is anatomy, okay. You should remember this. This is lateral side. Lateral meniscus is very special. Special is more complicated than medial. Okay, it's a very complicated structure like shoulder. There's a popliteus tendon here, like bicep in the shoulder joint, right? And also there is a Humphrey and Risberg, okay, holding this lateral meniscus. So that's why I told you meniscus lateral side rarely extrusion because there's like chopstick, okay, between the PCL and attached to the lateral meniscus, okay? And also there's an attachment close to the ACL insertion, and this is mobile. They cover about 70%. Okay, if you look at this medial meniscus, it's quite firm attachment. Okay, with about 50% intermeniscal ligament, that's PCL. Okay, and you see this hole. This is the popliteal hiatus. And if you probe the meniscus, you see the lateral side, there's a lot of mobility on the lateral side comparing to the medial side, right? So remember this anatomy of the lateral side so you can easily understand this discoid meniscus. So Watanabe classified this discoid meniscus into 3 types. So the first one is simple, is the complete coverage of the lateral side. This is first type 1. Type 2 is incomplete or partial coverage, less than 80%. And type 3, this is a complicated type. You see this Risberg ligament, right? Risberg ligament, and there's no attachment. You look at this, there's a meniscal tibia attachment for every type, but on type 3, it's very mobile because there's no attachment of the meniscus to the tibia. Okay, we call this the Risberg type. Okay, I show you the type 1. This is type 1. You see that is completely coverage. And many times you see the meniscus have some signal inside because this is there's some degeneration or a horizontal tear of the meniscus. If you look at the type 1, you see that this is complete coverage. But many times if the patient have no symptom, we don't have to do anything. Okay, this is type 1, complete coverage. Okay, in type 2, it is incomplete coverage. Okay, this still you see some gap here between the meniscus and this the ACL. This is a type 2. Okay, many times these 2 types has no symptom, but over time when the patient getting older, we're active, this meniscus can be torn and get symptoms. Okay, that's why it's a congenital but no symptom until one day meniscus get degenerative change or acute traumatic injury that produce symptoms. But in type 3 it's different. Type 3 the patient always come with snapping, okay, flexion, extension, because this type the meniscus is really mobile because there's no attachment on the tibia. You see on the lateral side there's some snapping, okay, in flexion and extension. And look at these arthroscopic pictures. See that this meniscus has no attachment to the tibia. Okay, this type is Risberg type. Okay, so So you understand three types. And also Jordan, this is Jordan classification. In Watanabe classification, they did not mention about the symptoms, did not mention about the tear, right? But this classification is better because they mention about the type, also the tear and symptoms, if it's stable or unstable. So this is more, can guide you for the treatment. So the treatment decision depends on the type, okay? Is tear or not? Is it symptomatic or not? Or is it stable or not? So you can decide conservative, partial meniscectomy or total meniscectomy. So the symptoms of the meniscus discoid, sometimes there's no symptoms, sometimes they have joint-like tenderness, and sometimes they have popping, snapping, McMillan test positive. So very wide spectrum, okay? From no symptom to symptomatic knee, like snapping, locking, okay, and pain at the lateral joint line. Physical examination, you can see lateral joint line tenderness, McMillan positive, okay? This I show you the snapping, okay? Is this the type 3, Risberg type, okay? This gentleman, he has the discoid meniscus, but now he's 25. He just have the symptoms on the lateral joint line. Okay, McMillan test positive. Okay, so look at the MRI. MRI, you can see that this is a thick meniscus in AP. Okay, full and thick, and sometimes you can see no attachment of the meniscus to the capsule. For the lateral X-ray, you can see the bow tie side. If you see this continuous of the meniscus more than 3 cut, I mean the full, there's no gap between anterior and posterior, more than 3 cut, or thickness more than 5 millimeters, this is a meniscus. Why it's easy to tear? Because this kind of meniscus have the mucoid fibrous degeneration inside, okay, and more disorganized collagen, and also that thickness and abnormal vascularity. That's why these kind of meniscus have tendency to tear. So treatment option depend on the type, tear, symptom, age of the patient. So if the patient asymptomatic, you can treat conservative, no treatment, just wait and see. If they're symptomatic, you need to see that is it stable or unstable. Okay, is it stable tear? You go in, you clean, remove the mechanical problem, the unstable meniscus, socialization, and you do some partial meniscectomy. We prefer to do partial. Okay, nowadays you try not to do total meniscectomy and partial repair. But for the unstable type, you also need to repair, especially type 3, the Risberg type. You need to repair the meniscotibial ligament. Okay. So this is the way to treat. So this is type 1. Type 1, many times the patient have no symptoms. Okay. But if the patient have symptoms, we call the socialization. Okay. But careful, do not make it too much. Okay. You still need to leave about 8 millimeters left for this meniscus. Okay. And many times when you do socialization, there's some horizontal tear. This meniscus is pretty good. Okay. The quality is not bad. Okay. So the outcome, short-term outcome is quite good, and also the long-term outcome of this socialization is quite good. So I show you, this is beautiful ladies again. She's 80 years old. She's Thai, but you know her parents have no children, so come to Japan, okay, to beg for a child. So she got these children from Japan. Yeah, that's why she has Discoid. Yeah, I don't know, but this is true. This is true. And now she go to Japan for working. Yeah. This is a correlation, right? So I go in. She is at that time. Yes, tsunami. Remember, many years ago, and she has suffering from this discoid meniscus. Yeah, right. I do the surgery for her, and at that time, after surgery, 2 weeks later, she need to fly to Japan to study, right? So when you go in, we found that there's no attachment of the meniscus to the posterior capsule, and this meniscus is quite thick, right? So I try to reduce it, but it's impossible. First, you need to do partial meniscectomy first, okay, to reduce the size. Okay, this is the same patient. We go in, you see that thick, okay, this Discoid meniscus, this Risberg type. So I start from cleaning the soft tissues and then try to reduce by inside out. Okay, inside out is quite good because you can use this tension of the suture to reduce it. Okay, even the first 2-3 stitches you cannot reduce. See that? Quite thick. And then we do the partial meniscectomy. You see that always after you partial meniscectomy, that will be horizontal tear. You look from above, it looks nice. Whenever you do partial meniscectomy, there's a degeneration or horizontal tear of the meniscus. Okay? So after that, you repair the meniscus back to the capsule. You can do all inside. You can do the posterior approach, repair like a person aunt, they prefer to use the stitch from the back. And then I do the all inside all together with the inside out. Okay? And I just saw her. She just come back from Japan. Okay? And she's quite happy. Now it's 7-8 years after tsunami. And now she moved to Japan already. Yeah. That is the true story. Unbelievable. Another situation, this is a patient that have the meniscal tear. Okay, you always see like this, and many times you can see the radial tear inside and also some cartilage injury. It depends on the chronicity. If the patient come to see you very early, okay, you can save the cartilage and also the meniscus. You see, it looks so ugly, right? So first of all, you just use a shaver. Do not use too much basket punch because you always cut it too much. You just remove the unstable part. You see that horizontal tear? We refresh it, okay, using the trephination, and then we repair this unstable meniscus. Okay, this is a posterior horn, right? After we repair that, okay, so again, okay, and finally you get the side. You see that cartilage? Yeah, always happen because of the chronicities. Sometimes you need to do also condyle transfer or microfracture for this kind of meniscus. Okay. Another patient, this patient also have meniscal, discoid meniscus. Okay. And always, many times they have the radial tear. Okay. Whenever you see the radial tear, you see that? This is the, actually I think this is like the incomplete discoid. And over time, the meniscus break and there's a hole inside. Okay. Like bucket handle, okay? But first you need to differentiate. This is not bucket handle. If you try to reduce it back, it's impossible, okay? Good. And after that, you see that's some condyle lesion, okay, on the tibia, always, okay? And I try to make an inside out, okay, like this, by the meniscal stitcher, okay? We found that is okay. And cartilage is not so nice. We make it many times because you know the radial tear is the most difficult to treat and difficult to heal. And also if you have radial tear, that means you lost a hook tension, okay? And the result not so good. So after I repair, I'm not satisfied with that. You see, it's not nice. So I take this out. Okay, every time you need to check again, okay? It's not nice. So I need to remove this and try the different way. We make an inside out for posterior, and for the anterior, the needle is not that curved, right? You need to make an outside in also. This is a combined, the outside in and the inside out, okay? Sometimes, right? You do like this, and I change these sutures, okay? So do your best because these are the young patients. You need to do your best to save his meniscus because he needs you to do this. You need to save, okay? After that, it's getting better, okay? So this is the combined, inside out, outside in. And sometimes, this is the Professor An Wei. He's a king of PDS. So, Professor An comes from Korea. So this is a radial tear. He prefers to use the PDS for all inside repair, okay? Like you do band cut. Yeah, this is not easy to follow him, okay? So this is the all inside way. This patient, as I told you, is the oldest discoid meniscus. He's Japanese. He's 70 years, but his knee is very healthy. You see the cartilage. Okay, do not judge the patient at the age. Okay, like James Hui, yeah, he still look young. Right. Yesterday you see him working on the stage, right? He limping, okay? Because of cramping, right? It's not because of your meniscus. Right. So this patient, I trim and I do the meniscus repair for him. He's quite happy, right? He's still like walking, running, okay? So, okay, sometimes it's very complex like that, okay? Like that. First you need to design how to do, not just cut it off. Because sometimes you see it very ugly, you try to use a basket punch. That's too much. I recommend you to use the shaver first. The unstable part will be debrided by the shaver, okay? And this is the anterior part. This is also the complex meniscal tear. So many studies about the results, okay, of this Discoid meniscus. Many times you have the OCD or cartilage problem. That's a complication. The risk factor for degenerative change is first is the age at the surgery. Also, the second is the amount of your meniscus. So, in conclusion, right, for the discoid meniscus, is it asymptomatic? Mostly in the type 1 or type 2. That's still no hole in the meniscus. You treat conservative. But whenever it's symptomatic, you look at the stability. It is still stable. Okay, we go in, we debride the unstable part. Okay, socialization, and then repair the rest, like radial tear or something tear from the posterior capsule. This is unstable. Yeah, you need to repair the meniscal tibial, okay, to fix it, to make it stable. And thank you. Don't forget, 2020. I support you. You should support us too. Patrick. Okay, bring 200 from Hong Kong. 200. Yeah.